hearing, and we're going to start off by telling you that the members of the board, the physician members of the board, or none of the physicians, this is not an endorsement of a drug. This is a topic for you guys to understand the laws and the history of how we got to where we are in medical marijuana. So right now, I thought this was the objectives we want to talk about is we want to review the rapidly changing landscape, the history, the current status of the multi-agency medical marijuana program, talk about the role the board has in current law, and review the board's rules on marijuana therapeutic use. Now, you might not know this, but the board's rules are online at www.lsbme.la.gov, and you can go to the physician rules, go to chapter 77, and you'll be able to see basically what we've been talking about. So, if you look around, right now there are 11 states in the District of Columbia that have legalized recreational marijuana. 20% of Americans live in those states right now. Since 2014, Arkansas, Alabama, Florida, Georgia, Mississippi, and Texas have approved medical marijuana. 33 states, along with Guam and Puerto Rico, have medical marijuana laws. And any of us clinicians who elect to participate in these programs should expect regulations to continue and change on an annual basis, and I'm going to show you that in a little while. So who is recreational marijuana? Well, California, Washington, these are the ones, okay? And I think as this moves along, you're going to see more, there's a trend to more and more legalization of this. So we're going to talk about some of the impeding factors that you need to know about as you choose to do this or not. What you see in different medical marijuana states that's different is that you have a different enrollment for patients. You have different training of prescribers, recommenders, or salespersons. You have qualifying conditions for which it can be used, and they vary from state to state. You have the types of products that are available. For example, in California and Colorado, medical marijuana is simply the same as recreational marijuana, but you give a card that the state verifies you have the bona fide medical condition and are qualified to get medical marijuana, and you get a discount on the price. At the other end of the spectrum is Louisiana, which has a highly processed, near pharmaceutical grade product that's only legal in Louisiana. So again, you have this broad spectrum, and we'll talk a little bit about it as we go along. The methods of distribution are different. In California and Colorado, there's all kinds of marijuana stores, THC boutiques, if you will. In Louisiana, we have 9 and soon to be possibly a 10th certified marijuana dispensing pharmacy, and they're located throughout the state. We have 1 in Orleans Parish. And so around the state, those numbers, some people are closer or farther away. It's a population density issue. And the Board of Pharmacy makes that decision based upon laws that the state passed. And right now they're considering where the 10th one's going to be. We don't know. Now, one of the things I really want to talk about, I apologize, I got ahead of myself. This Cole Memorandum and Rohrabacher-Farr Amendment. The Cole Memorandum was a memorandum issued by an assistant attorney general in the first Obama administration that said they would not enforce laws for marijuana. The Department of Justice would not enforce the existing federal laws. And that led to the outbreak of the legalized recreational marijuana and the outbreak of more and more medical marijuana. Shortly thereafter, Congress enacted this Rohrabacher-Farr Amendment. Has anybody ever heard of that? Rohrabacher-Farr tells us that it's an amendment that has to be re-upped with every session of Congress. It is a specific prohibition on the Department of Justice spending any federal funds to enforce marijuana laws. So right now, if they wanted to, they couldn't stop us from doing it because they're not allowing the money to be spent to do it, and they would be violating the Rohrabacher-Farr Amendment. Cole Memorandum was rescinded in 2018, but Rohrabacher-Farr has continued to be re-upped every year. So understand, if this does not get re-upped in this session of Congress, then they can start enforcing these laws, and all of the activity we're doing around medical marijuana in Louisiana could come to a screeching halt. But again, nobody knows what Congress is going to do because I don't think they know what they're going to do. All right, so one thing is there's no state like Louisiana. We looked at all 50 states when we put this together, And there's not a single state that has anything like we do here. There's some that have a different medication, but none that do it quite like we do it here. So we'll talk about how we do it here. But this is the, the various states nearby all around us that do it and how it's done. And I think it's important to know that Texas does not allow the kind of substances that we have here. So if a patient from Texas comes in to Louisiana and gets a prescription and filled at an approved pharmacy, or recommendation, please, if I say prescription, slap me, it's a recommendation, I'll tell you that later. They take it to Texas, it's completely illegal in Texas. So they could go to jail for getting the medical marijuana that we recommend for their state, because their state only allows this low THC for patients suffering from epilepsy and nothing else. So it's a lot different, so you have to be careful about interstate use and all of the federal regulations that apply. So how did we get to where we are? Well, Edwin W. Edwards signed the original law for glaucoma and chemotherapy in '78. Well, nothing happened. In '91, they amended the law to add spastic quadriplegia, but still nothing happened. In '94, the Department of Health and Hospitals concluded that they have no statutory authority to regulate or control medical marijuana, so continued, nothing happened. In 2015, Jindal signed Act 286, or the Allison-Newstrom Act of 2015, and it set up a system that the responsibility for implementing medical marijuana program between 3 state agencies, the Board of Medical Examiners, the Board of Pharmacy, and the Department of Agriculture and Forestry, okay? And in 2016, we amended it, supplementing, clarified prescribing versus recommending. It had qualifies conditions. And then we expanded the conditions in 2018. There are now 16 conditions. And in 2007, Act 207, in 2084, 2019, we changed some of the requirements and modified it and lessened the fact that we originally had, for example, only physicians domiciled in the state of Louisiana could recommend medical marijuana. They've now changed that, but we still have the rule that they have to see the patient in the office in Louisiana. They could have a license in Florida and live in Florida and come to work in Louisiana. That's what this was to address. So, this statute on the therapeutic use of marijuana is effective until USDEA reschedules from Schedule 1 to Schedule 2. Remember that it currently is a Schedule 1 drug, it's not a Schedule 2. And under Louisiana law, an MD licensed to do so may recommend any form that's permitted by the Board of Pharmacy rules except inhalation. And that's one of the things they changed in 2019. They allowed meter dose inhalers, but they do not allow raw approved products. And they can use it only for patients suffering with a debilitating medical condition. Now in 2018, they added chronic pain to the debilitating medical condition, and the anticipation was that there would be 100,000 patients that would be now utilizing medical marijuana in Louisiana. I can tell you that the numbers are dreadfully lower than that. It's probably not even up to 7,000 patients in Louisiana. It's probably closer to 5,000 right now. But really, for purposes of what I apologize, I hit the wrong button. Okay. For purpose of the part, recommend or recommended means in order. So that's what the law says. Recommend means in order from a physician licensed and in good standing with the Board of Medical Examiners, they're authorized by the board to recommend medical marijuana that is patient-specific, disease-specific, in accordance with paragraph 2 of this subsection, is communicated by any means allowed by the Board of Pharmacy, the Louisiana licensed pharmacy, and a Louisiana permitted dispensing pharmacy is described in subsection G, and is preserved on file required by law or federal law regarding medical marijuana. So this is right out of the statute. Now what does that gobbledygook mean? Is first of all, if you write a prescription, that violates federal law, and everybody was afraid their doctors would get in trouble. So they changed it to a recommendation. But they said it's an order. Well, we all know what an order is. You have to give a dose, you have to give a frequency, a duration, and all those kind of things. So when we wrote the rules, we defined clearly what that says as what it means to all of us. It means an order. And so that's how we got to where we are. Some of that is the rules writing, and some of that is the statutory writing. But the order is sent to the pharmacy, and we intended it to be electronic, But the electronic prescribing systems have not kept up with the laws and the changes in Louisiana, and the fact that a lot of the companies don't want to fool because it's Schedule 1, so we allow it to be faxed. You can give the patient a copy, but the Board of Pharmacy says it cannot be brought by the patient like a regular prescription to the pharmacy. And then we review the data on a regular basis and we make recommendations, but that's kind of taken out of the law too now. So these are the 16 conditions, and I think when we added this group here in the last couple of years, they thought the number would get much bigger, but it didn't. And then the autism spectrum disorders are really for children, and particularly minors under the age of 18. And there's been a lot of controversy because in the law it says that you have to have a consult, and we'll talk about this. So for autism spectrum disorder, it has to have these are the definitions that the law is looking for. If it has any of these, then you can write it, but no physician shall recommend medical marijuana for a patient under the age of 18 unless the physician complies with the provisions of this section and consults a pediatric subspecialist. So naturally, who defines the definition of pediatric subspecialist? Well, our rules do, and the board did. And it was extremely controversial, quite frankly, because we said that we wanted to be as broad as possible because some people said it should just be pediatric neurologists. Well, there's not 20 pediatric neurologists in the state of Louisiana right now. And sometimes people live far and far away from the pediatric neurologist, don't see them very often. And if you have 2 kids with autism, it could be rather difficult. So people asked us to make it open and broad, and, as well as the legislature. So we define the pediatric subspecialist as a person who practices, who the bulk of his practice is treating patients with pediatric autism regardless of specialty, and is licensed in any state of the United States. And that allowed people to have the doctors could have phone consultation with a doctor in New Jersey who knew a lot about this and saved the patients the cost of going around to find somebody to do it. And of course, the pediatricians took great umbrage with that and ultimately they got a resolution passed in 2019 legislature, Senate Resolution 255. And basically, they've done a study to see if they should change that. Pediatricians and family practice were outraged that we did it that broadly. And so we're continuing to struggle with that, and we anticipate that that will change in the next session of legislature. So we regulate the recommenders and grants what's called a therapeutic marijuana certificate, and we do the rulemaking. The Board of Pharmacy promulgates rules related to the dispensing and establishes standards for adequacy and an adequate monthly supply. It establishes testing standards for THC concentrations. It establishes security requirements for dispensaries. And as I said, it's limited to 10 dispensaries, the initial 9 and 1 to be determined, and they haven't finished the 10th. The Department of Agriculture and Forestry developed specialty license for production, and only 1 license can be issued. And it was first refused to LSU and Southern. They both took that up. LSU was through a company called GB Sciences out of Nevada, was the first to have a production and available pharmaceutical grade product. And it is in a tincture form of varying concentrations. And we'll talk about that a little later on. So this is an important thing. The levels of THC in any marijuana produced shall be reduced to the lowest acceptable therapeutic levels available for scientifically accepted methods. Now the interesting thing is, this is where we have a lot of lack of information. It's not a lot of scientific accepted methods. And so we urge people to start low and go slow as they increase the dose so that people don't get into trouble. But that's a statutory requirement. So we initially convened a medical marijuana expert panel to review the available literature regarding medicinal cannabis. The committee made recommendations to the board and submitted to the Health and Welfare Committees of the 16, 17, and 18. And we recommended the addition of spasticity, recommendation of language to promote weight gain in HIV and AIDS and wasting syndrome. We recommended removing glaucoma because the ophthalmologic literature said it really only works for a very short time and not long enough to make it a valid medicinal use. It's like if you take the medical marijuana, in about 15 minutes, the effect of the glaucoma is gone. It's reversed back to its glaucoma state, so it's really of no value. And we recommended pursuing avenues with our researchers to conduct usual medical research. Well, the legislature does what it wants, and they didn't change any conditions in 17. We didn't recommend any. In 18, we recommended no new conditions. They added their own. In 19, they decided we didn't want to hear from the Board of Medical Examiners, so we couldn't get reports to them anymore. So they added the new conditions. They changed the domiciliary requirement for the doctors that prescribe. We used to have fail-first protocols. So if you were using some drug for the problem that wasn't working, then you could go to medical marijuana. You couldn't go first to medical marijuana because you had to fail first on approved products, but now that's going away. The legislature in its wisdom thought that was not needed. They're now allowed the metered dose inhaler product. It looks like we might see that for March, but if GD Science is now known as Welcana, who's the contractor for LSU, if they have it up to their normal speed, we probably won't see it until September, but we'll see. And then the legislature actually adopted the board's language for pediatric subspecialists. They're licensed in any state, principal practice about treating any specialty that treats pediatric autistic patients. And the legislature thought our language was good enough that they adopted it right from our rules. So that further incensed the pediatricians, but I think the legislature, I think you have to come to this from an interesting perspective. When I talk to individual legislators, they really feel like this is a compassionate thing that they're doing. They get a lot of anecdotal tales and stories about things that just are so terrible and that it would be so great if it worked. And not a lot of science, but just they get these people who are having real crisis, and I think these legislators want to do the right thing, they're sympathetic, and they want help, and this is the way they chose to do it. So we have completed the revision of the rules, and we changed the patient limits, the revisit rules. We talked about the CONANT implications, and then the chronic pain treatment for rules for chronic pain. So if, for example, you choose to be recommending medical marijuana, and the patient is coming to you for chronic pain, but they're also seeing a pain specialist who would be required by law to do their narcotic pain prescriptions in a certain way and follow the rules. When they go back, you may give them the marijuana, but when they go back, their chronic pain doctor will probably dispense them from the practice because they violated their contract in that they're using now Schedule I substance to treat their chronic pain. The patients are getting caught in the middle, quite frankly, because the doctors that do medical marijuana generally they only take cash, number one. Number two, it's very expensive. Number three, the patients want both, and the medical marijuana doctors don't want to fool with the requirements that the board has for chronic pain. So that maybe was holding it down, but certainly I think everybody agrees that the chronic pain rules serve a very important need in the opioid crisis, and that's why we're patterning this for the same thing. Yes, I'm sorry. CONANT decision, anybody ever heard of the CONANT decision? That was a case out of the Western Appeals Court of the United States, and what it said was the California law says you can recommend, but you can't specify. You can say that the patient is able to take it, but California people tried to put regulations like we did, and unfortunately they couldn't do it because their state law was not significantly written. And our legislators looked at that decision to come up with the concept that a recommendation is in order, so we really have the ability to be treated like a medicinal product. And it's an attempt by the legislatures to try and become the FDA and the scientific basis for the fact of the usefulness, but sometimes they fell short. So the board's marijuana rules no longer specify the interval for revisit, and it's dictated by best medical practices. Rules required to treat as chronic pain follow the board's pain rules, and we've already defined a consultation for pediatric autism. Now, these rules are now in process, and they should be finalized and published in the register in about 3 to 4 weeks, and then they'll be going to the legislature for oversight. They can do what they want to do with it, and we'll deal with it at that point. Does anybody know how a rule is made? So any of these rules, you might find out why does it take so long? Let me tell you what happens. The board decides it wants to make a rule about anything in its purview. We draft the rule, the board approves it. We send it to the state to go to the Occupational Licensing Review Committee, which is a process set up in the 2017 legislature to try and avoid the antitrust implications of board regulating other members of the practice. because of the North Carolina dental case that everybody probably knows about if you pay attention to antitrust in medicine. So then it has to go from that point to a hearing, publication in the register, then a hearing at our board 35 days later. Then it goes back to the Occupational Licensing Review Committee, especially if there's any changes, and then it goes for final notice publication, and then it waits 35 days after final notice publication for the oversight to occur. So with a tailwind, you're looking at 6 to 8 months to get a rule passed in Louisiana. It's just they've made it so cumbersome, but that's what the state wants to do, so we do it. So let's talk about the therapeutic use by patients suffering from the debilitating condition. You must have conducted at least one in-person exam at a physical location in the state, and you're responsible for ongoing assessment, care, and treatment. So you just can't say, here's your medical marijuana, let somebody else adjust it. If you prescribe it, you got to adjust it and maintain it. The debilitating conditions described, but also allows for additions by the legislature. So if in the next session they decide to add chronic headaches or migraine headaches, they could put migraine headaches, and some people would take it. I'm not sure what they're going to do. We think that they're going to kind of revamp all of this and put all of this kind of stuff out of business and go to a card system like Colorado, but we don't know. Nobody knows what they're going to do. The Board of Pharmacy has the authority to define the forms of marijuana available to providers. And the patients have to be residents of the state seen in a clinic in the state. That's the problem, that interstate illegal substance and across borders. The MD has to be registered with the board and comply with the rules. There's no limit to the number of patients a therapeutic marijuana holder can treat. You cannot delegate it to any other person, so your PA can't write the order or recommendation. Your nurse practitioner can't do it, can't evaluate the patient. It has to be done by an MD at this time. You cannot examine the patient at any location where medical marijuana is provided. So